In this lecture, we will discuss the Sgarbossa criteria and how it can be used in the presence of left bundle branch block to identify acute myocardial infarction. If you recall, right bundle branch block does not affect the diagnosis of myocardial ischemia or infarction and is not always pathological. However, this was not the case with left bundle branch block. In fact, left bundle branch block is always pathological finding and affects cardiovascular mortality. It is more common in patients with structural and ischemic heart disease, and the issue here is when trying to assess for ischemia on the EKG in the presence of left bundle branch block, it can be difficult to discern it. And this is due to the changes in left ventricular depolarization and repolarization, which result in secondary QRS and STT changes, respectively. It is the secondary STT changes that can mimic or mask ischemia. For instance, left bundle branch block can mimic ischemia with ST elevation in leads V1 and V2 that is associated with ST depression in leads 1 AVL, V5, and V6. And left bundle branch block can mask ischemia because the STT changes caused by the bundle branch block are stronger than those STT changes caused by ischemia, and therefore can mask those ischemic changes. Now, in order to overcome these issues, the Sgarbossa criteria has been proposed for detecting ischemia on the EKG in the presence of left bundle branch block. It consists of 3 criteria that are applicable to all left bundle branch blocks, regardless of the time of onset. Each criterion can receive anywhere from 2 to 5 points. A cutoff of 3 points or greater has been shown to be have a relatively low sensitivity but very high specificity for acute MI. So let's take a look at this criteria. So 2 points are given if the ST elevation is 5 millimeters or greater with discordant QRS complexes in leads V1, V2, and or V3, okay? So here we are with this criteria, okay, and we're saying this first one gets 2 points here if we have discordant ST elevation. So remember, discordant when the main QRS complex is going in the opposite direction of the ST and T wave. So here's our QRS complex going mainly downwards, okay, and our STT waves going mainly upwards. We call that discordance, and we want here not only that discordant to be present, but also ST elevation of at least 5 millimeters, okay? So 5 millimeters, which is the 5 small boxes, and we can certainly see that we have this present in this case, okay? That's greater than 5 millimeters. So this would be 2 points for that. Okay, now 3 points are given if there's ST depression of 1 millimeter or greater in leads V1, V2, and or V3. Okay, so now we're just looking for ST depression, no concordance or discordance. So ST depression of at least 1 millimeters, again in leads V1 to V3. So here we are in V1 to V3. We're finding our J point, which is here, our baseline that's there. And we can see that's more than one small box. Okay, so that gets 3 points. All right, so we already hit 3 points, which means that there's a high specificity for that acute MI. Okay, now the last criterion gives 5 points if there's ST elevation of 1 millimeter or greater with concordant QRS complexes in leads V4, V5, V6, lead 1, and or lead AVL. So now we're looking at concordant changes. So now they're going in the same direction. Notice our arrows here. Okay, our QRS complex, main vector upward. Okay, same thing with our T wave. We also said that there has to be ST elevation of at least 1 millimeter. So here's our J point, okay, our baseline here, and that's at least 1 millimeter or one small box. Okay, so that gets 5 points. All right, so that's a great criteria, and that would already put us over the top. So that's the Sgarbossa criteria, and if there are at least 3 points present, then there is a very high likelihood for an acute STEMI in the setting of left bundle branch block. This criteria has also been shown to be used in patients that have ventricular paced rhythms, okay, so it can be helpful in those. Also, don't forget that it is normal to have T-wave inversions in the lateral leads, 1 AVL, V5, and V6, in the presence of left bundle branch block, and their absence actually suggests ischemia, okay, and we saw that here. Here's an upright T-wave in this case. Okay, so let's review what we discussed before we end. So remember, left bundle branch block causes left ventricular depolarization and repolarization, so we get these QRS changes and the STT changes that can mimic or mask ischemia. So we said we should use this Sgarbossa criteria to overcome that. Okay, and that Sgarbossa criteria says that we can detect acute MI or left bundle branch block or a ventricular pace rhythm if we have at least 3 points present. Okay, so there's 2 points if you have discordant ST elevation of 5 millimeters or greater in V1 through V3. Okay, and you get 3 points if there's ST depression of 1 millimeter in of at least 1 millimeter in V1 through V3, okay? And then 5 points if you have concordant ST elevation of at least 1 millimeter in those lateral leads, V4 through V6, 1 in AVL, okay? So if you have that present, that's very specific for an acute MI, okay? Remember, it masks an MI because the changes, the ischemic changes to the ST and T wave, okay, are actually not as strong as those that come from the bundle branch block, and that's why it can mask and overcome them, and you may not even see them, okay? So the Sgarbossa criteria can really help us to identify ischemia in the setting of left bundle branch block. Well, that's the end of this lecture. We discussed the Sgarbossa criteria and how it can be used in the presence of left bundle branch block to identify acute myocardial infarction. I hope you learned something.